Swayam Prabha. Digital India. Educated India.
Procedure. Very good. That's where we stopped. So I'm glad you asked this question. This is what we are talking about. Efficiency was the resilience for any system, right? Healthcare system is no different. Everybody knows that how you explain efficiency versus effectiveness. Efficiency versus effectiveness. Any thoughts?
Effectiveness is, have we got the outcome that we were looking at? Have we achieved the desired outcome? Efficiency is the most maximize saving resources and getting the work done, and the is efficiency, saving resources or optimizing resources.
You are right there, ballpark. All these things are correct. Sundar, any thoughts?
See, effectiveness is like how good you are able to do something, and effectiveness is, are you able to do that with as limited resources or as whatever you have in hand.
Absolutely. So I like to say the following way to make it even more simpler for us to understand. Doing the right things, effectiveness. Doing the right things. Doing things right, efficiency. For efficiency, you have a system that is defined for you. You cannot go and define a new system. That is a system. Within that system, are you doing things right? Are the patients discharged on time? Is the inventory policy the right way? Is demand forecasting happening? And how are the errors in the demand forecasting handled? All these are the right things. You have not changed anything about how you are forecasting. Within that, you are saying, I am forecasting, I am getting an error of 2%. I can continue to reduce the error, but at a given time, my error is 2%. How am I using the 2% to adjust my system on inventory? That's all efficiency based. Effectiveness, you are completely now tinkering with the design of the system itself. Doing the right things. Doing things right. One way of looking at it. So, within that doing things right, how do you also bring in the resiliency? Because we have established the following, right? We've established since morning that healthcare is very fragmented. Many players are involved. Many things can go wrong. Complex. We talked about either it's a procedure that is complex, the system itself is complex, and subject to disruption. It could be small. That small valve that you saw this morning could be the disruption, could be bigger disruptions like COVID. So disruptions can continuously happen. So these are common kind of challenges in any system, and they are no different in the healthcare system. So within that, efficiency, meaning how are you looking at all these things that are posted in the down part of it? How do you look at the supply side of things? The distributor relationship, going back to the morning and Ishan, what kind of relationship that they should have to expedite the products to come in when there is an emergency? What could Ishan do differently in the future on demand forecasting to get it more accurate? What about the enterprise resource planning systems? A lot of systems now make determinations as to when to order, how much to order, where to order, what price. All these are locked in. We recently looked at using a simple large language model kind of a software. We looked at contract language for hospitals and its suppliers for 2,500 hospitals in the US for certain types of supplies. What verbiage, what's the length of time they have negotiated. It was not complicated products either. And if the procurement people don't pay attention to these details, then that variance in that language translated to variance in pricing, variance in inventory. You are writing a language that says strictly 2 weeks lead time, somebody else giving 2 plus or minus 1 because they are getting a 1% discount. The variance in the inventory costs in the long run hurts them even though they are getting that 1% discount. So to look at the whole idea about how the ERP systems, now this is language that you wrote, not somebody else wrote. You sat down and wrote. Now once you put it into an ERP system, it doesn't remember. It just uses. Here is an interesting thing that I have learned over the years in forecasting. Something called the safety stock, right? In the inventory, people know about safety stock. This is the just-in-case inventory that I need, right? Things like what happened today in our example with Ishan. Ishan is going to be more conservative in the future. He's going to say, I did not have this 2 weeks, so I might make it 3 weeks kind of a inventory in my system. That 1 week extra inventory is my safety stock. Most of the times, a safety stock from theory is to look at the variability in the demand, right? So demand varies. Not everybody is not going to consume exactly the same. There's variability in the demand. The variability in the demand statistically can be used with some service levels. How tolerant are you in providing a 90% service level versus a 95% service level to your customer? What does it mean? 90% service level means 10% of the time you might not have that product. Is that the end of the world? Yes, it is in a hospital setting, right? 95%. Still, now, it's not across everything. When this valve is not available, let's say the service level was 90%. Mary still had an option, an expensive option, but could get another option to provide the same service. So it was not end of the world. It was an expensive option. 12 times most expensive. That's what at least the case said. 12 times more expense was incurred because it needed an additional nurse to come in. So it's not the end of the world. So if this had a 90% service level, maybe not end of the world. Something else like the Bentel procedure, I'm going into and if they don't get that valve, that's very difficult. So there they may have 98% service level at a safety stock. But anyway, let me come back to the ERP systems we are talking about. Majority of the times, the systems like ERP do not actually track the variability in demand. It's very difficult to track it and put it into the system. But instead, they use forecast error as a surrogate for variability in demand. So I forecasted 10 units. Actually, I used I needed 12 units. So I was off by 2. I forecasted 12 units. I only needed 10. I was off this way by 2. So this is called the forecast error, right? So over a period of time, the forecast error is used in many of these systems as a surrogate, as a substitute for actual variability in demand. Now, the problem with that is, what if you are forecasting badly? You have not chosen the right models or the right data or the right fine-tuning of your models. So, the error is not really a variability in demand, but an error truly in not doing your forecasting right. But the system doesn't know that. The system is going to set it up as parameter for your error and use that to set a safety stock. So that is why it is critical that human intervention has to happen, because you are the one that knows, no, I'm not going to need 5 units extra. At the best, I only know I need 2 units extra. That's only the human dealing with the system knows that better than anybody else. So constant evaluation of these ERP systems is critical to improve the resiliency of how it is used. So information technology is a curse and a blessing. So you got to understand that. Sundar, any thoughts? Okay. Alrighty. Yes, please. Go ahead. Give mic, please.
Different from the buffer stock. This safety stock,
Safety stock and buffer stock are the same.
same.
Alternate word for it, that's all. I call it safety, you call it buffer. Okay, let's keep going. So, how do you constantly, you are talking about how do I mitigate the complexities? So, from morning we said healthcare is complex, but we know how to conquer the complexity to some extent. So, how do you look at it? Definitely, you are looking at, mitigation strategies that are more robust. We saw one such strategy this morning with Mary. She was able to go and do alternative way of providing that service. What else is available to you from automation or from mitigation? One of the things we have learned after COVID is more scenario planning, right? Many organizations are today looking at scenario planning as a big tool. The what if, the length of stay, to go back and say is not 5 days but 7 days. What happens to that kind of scenario? What's your bed capacity now? And so on and so forth, for which you are constantly leveraging your data. So my data has now gone in that I stayed there for 5 days overall in an ICU for a dental procedure. So the data on dental procedure is either going to be skewed a lot because of my stay or going to stay on average. So that data analytics is important to look at. The other one is you are not alone. Though we say a lot of players are there, how do you enhance the communication and collaboration? Here is what they did. When they did do to ask my pacemaker to be done, immediately they were collaborating and communicating with the people who are ready to do that surgery. Because if that communication and collaboration doesn't happen, then they will have their own schedules. Because that's a different group that is doing the pacemaker. Remember ICU? ICU is a place. It's got some specific place and a bed. People are coming there to give different kind of services. The cardiologist comes there to give my dental procedure. That led to decision that I need a pacemaker. That's a different group that has to give the pacemaker now. Now, if the collaboration communication doesn't happen in an integrated way, then that delays is going to happen. And this ICU is still delayed, which is an expensive tool. So that's important in enhancing collaboration and communication. Now, why is it a supply chain issue? Because pacemaker, today there are 6 different types of pacemakers. Actually, I wrote a case on, I didn't even realize when I wrote a case on pacemaker, one day I'm going to get it. Long time back, I wrote a case. Different types of pacemakers are there. So it's not like your body immediately says this is the right type of pacemaker. So they have to procure that pacemaker that I need. They have to customize that pacemaker to the rhythm of my heart. So there are some things to be done in a procurement there. So that is why it becomes a supply chain issue. It's not just another doctor is available to do the surgery. Behind that is the kind of supply chain needed to support that surgery.
Right. That's perfect.
Poor supply chain. Yes, absolutely. So then other kinds of things that are happening is, as I said, many of these healthcare supply chains go through distributor systems. And so warehouse becomes a very critical part of how you put it together. And so how the automation of the warehouse becomes an important part. So the whole thing leads to the technology and innovations side of things. Continuing with the mitigation strategies, we talked a lot about the collaborative supply management, the dynamic demand side management, the scenario planning or the contingency planning is what I think Sujan is pointing to us as the scenario planning is the contingency planning. And you divide this into both proactive and reactive kind of strategies. how much can you do it ahead of time? Mine, up to the Bentel procedure, was proactive. My cardiologist said, you don't want to wait till you get a heart attack to do this. You are reaching a point where you can get a Bentel procedure done. Basic driver was a birth defect. The basic driver was a birth defect in the heart. So it was predicted this was going to happen. An incident could trigger many times. Many times it's an incident. A heart attack is an incident that triggers these kind of procedures. To me, I was lucky that such an incident did not happen. But then the pacemaker was a reactive one. They had to react to the conditions and do. So if you look at even here, one is the patient population going through that. Even otherwise, you look at proactive strategies like the demand management, your information management utilization, information rich, not just data rich. And then how do you do the product management? Different kinds of product, the pooling kind of services that supply chain that the professor talked about. Reactive strategies, once things happen, how are you going to? Still, any system has to react because you can't plan everything. How well you react is as good as how proactively have you planned. Both are critical part of it. And so integration of supply chains is one such strategy behind good reactive. This morning we talked about, how we produce that product and people were not integrated. If they are integrated, that would have helped a lot. That's a reactive strategy because once your team said, I don't have enough, if the other teams knew it ahead of time, they could have planned. They could have gone to another source if there is there to get more. If they wait till you provide it to them, saying you did not provide them enough material, then that is very difficult because now I got only one good product because of that. So the reactive strategies in terms of supply chain integration, supply chain redesign is, supply chains are not written in hard stones. So you continuously think about how do I redesign my supply chain. So it's expensive sometimes. Sometimes it is needed. Sometimes the redesign comes more through digital strategies, right? So those are some of the things. Any questions, comments on this? So this is one very complex area where four things unify. You don't see that in many industries. You look at the delivery side, which is the care side of things. You have all the delivery people, right? The retail pharmacies, the hospital systems, the clinicians, all the ancillary services. Then you got the schools, CMCs of the world, all put together. They all have to perform together from a delivery perspective. It's not a free service. You have the finance side of things. So again, different kinds of things. In many places, you're talking about who's financing the healthcare. What percentage is government? What percentage is private? What percentage is insurance? So all those things. Take two very close countries, Singapore and Malaysia. Singapore is quasi-private based healthcare. Malaysia is government-based healthcare. I have studied both these healthcares in carefully, and you could see outcomes are very different. Even though Malaysia is easy to get drugs, that culture is there. Let's go to a pharmacy. It's very cheap to get drugs, but outcomes are very different. So when I say outcomes, particular kind of illnesses and how long do you suffer with it? How do you come out of it? Singapore is more hands-on, try to be more preventive, invest more into the population healthcare, and so on and so forth. So financing, I looked at the financing aspect of it per capita financing, very similar between Singapore and Malaysia. So it's how that financing is used, not what the financing is, that has an impact in healthcare. Policy making, obviously, you're looking at a large population like India. Policy making is much more complicated, the rural versus urban divide. And of course, all these we are talking about is because how do innovation go into, what Professor Sundar said about the apps. I mean, it's very difficult to go into rural areas and find out. It's easy to tell. I asked him a very simple question. I said, why don't you do telemedicine? It's not easy. People don't even come to the regular healthcare. They're not tech savvy. Asking them to sit in front of a computer, answer questions, they get petrified, all these kind of things. Whereas they like to deal with people. So people can go and talk to them and use this app to communicate to other policymakers and decision makers. I think it's a brilliant way of doing that. So, the innovation that is happening in the digital world, and how do you leverage that, and how do you bring it to supply chain? I think you all have a very, very important role to play as you go forward in your lives. Any thoughts, comments as you look at the ecosystem map of supply chain? Depends on whom you are delivering. Again, the value is to the customer, right? If it's an end customer, that's a different one. I mean, they would love to see it, like anything else, come as quickly as possible. If you are now looking at a hospital as your customer, then the last mile delivery is more in terms of, are there any emergency medicines that they are looking at? Because the rest, they would love to see things planned ahead of time, have the pharma filled, not at the last minute. So, depends on who the customer that you are looking at as a last mile delivery customer is. Consumer importance is important, right? Why do they need it is critical. Trends now coming to India, a lot has gone into budgets in terms of increasing the investment into the population's well-being and health. But the problem is still in terms of the urban-rural divide is huge. Transportation infrastructure is huge. The last mile and where you're delivering, all those kind of things exist in a very interesting, challenging way than many other places, right? So those are things that yet to be. But you could see the trend in market size that is increasing in India. And you could see the source there that Sujan pulled from. Some of the things that you know of more than I do, demand is extremely strong anytime. Pricing manpower and medical colleges, government support, opportunities. I see more people talking about being in policy or being in clinical and administrative and managerial type of thing in healthcare is good. I want to see more people talking about I'm in supply chain in healthcare. Would love to see that more happening. Let me tell you an interesting statistic. It's a very smaller country compared to India. US is what 350, 360 million, to 1.4 billion a year. But around about, I would say, 80 large healthcare systems are there, hospital systems in the US. Almost 50 to 60% have supply chain experts that were trained at Arizona State University. So we played a big role in not only putting people in supply chain, but in C-suite role, chief supply chain officers in healthcare. So thereby today, in the medical education in the US, we have made inroads making supply chain one of the electives. We couldn't make it compulsory, but electives for the medical training. Because I've done studies where I've shown that a little bit of thought goes a long way in doing savings. So we looked at certain types of surgeries across 3 different types of hospitals in the US. One, where the doctor is employed as an employee of the hospital. Second, where the doctor has a contract individually with the hospital. Third, where the hospital has contract with a group of doctors that have created their own consortium. And we looked at the cost of surgery for a similar type of surgeries, like a knee replacement, as an example, or a heart surgery, which needs critical care parts which are expensive, which is where I do. we looked across these three hospital systems. Which one do you think had the lowest cost? I'll give you the three hospitals again. Hospitals where the physicians are employed. That's the only hospital they work. They are wage earning from that hospital. Second, the physician individually is a consultant to the hospital. Third, the hospital writes a contract with a group of individuals who are either cardiac surgeons as a practitioners or with knee replacement people. So these three different types, which one do you think will have a lower cost of a particular kind of surgery that is done across in these three? Why? So the question then becomes, why would that be lower? Okay, let me preface my question by saying the cost of the surgeon is not part of the analysis. The cost of the surgeon is not part of the analysis. Now let's go back and ask the same question, which one will be lower? Alignment of incentives is very true. So, I would put it this way, alignment of choices. Okay? So, in these three, remember I said my premise is, I don't care about what you pay the surgeon. That doesn't figure into my cost, because that's a market-driven one. If a cardiac surgeon is making this much, you are not going to pay. This is not a movie star. Pay 10 times that. So the market is deciding what the salaries are going into any surgery. Sometimes that is even capped by the government payment system. Government is not going to pay more than some things. So it comes down to supply chain costs. So our study focused on supply chain costs. What is supply chain cost? The cost of the materials that are used in that particular surgery. Rest are all labor costs. Assume the labor cost is market driven. Not much variability might happen. So here is the choice of the products. The Mayo Clinic was the one that we looked at people who are employed. They said among stents, you have limited choices of stents. Among the effective stents that they use, not that they're going to use an ineffective stent, they have limited choices. As you move across to my other two models, the choices were dictated by the individual doctor's preferences, which they would say, if you do not give me this particular choice, I can go to another hospital with the same patient and get that procedure done. Who is ready to accept my choice of? So that increases the cost, because if a hospital manages one type of product, then they have a better leverage on writing contracts. If they are going with many suppliers for the same product, what happens? The volume drops. And that has an impact on scale and cost. So, as it may sound very simplistic, the choices increase the cost of the surgery rather than the labor cost. I'm not going to the labor cost. That's a different one. So, it's important to understand those things.
That was during the interim budget allocation. But 2.5 is a full budget.
Yeah, that's what I think Susan is also. Yeah. So part of the variance you could see, my friend, is COVID-related expenses are not continuing, which needed extra investment, that is. Part of it is not complete data yet, so it may go up to 2.5 or more. These are some of the important main components if you think about the healthcare supply chain. But everywhere, India is not alone, but more that affects. Again, be careful when I say this is the healthcare supply chain part of it, the components they are talking about. So product selection and procurement, we talked about this a lot. That's a very important one. The more people are asking about designer product for something, the more people come to know, I want to have more dental procedures here, then the product selection is affected by it. So the global nature of treatment plans and procedures, especially in areas like cancer treatment, that has an impact on product selection. And higher the cost, more procurement issues. When go back to that dental procedure is one of those, two of those components that you see that in the handout I gave. If you are doing it in India, it can only be procured from abroad. You cannot locally source it. If that is true, that continues to be true, then the costs are dictated by that. So that's why I mean by product selection and procurement. But that's only one part. You can procure these things. How are you going to inventory them? Who's going to bring the last mile to you? All those questions is the warehousing and inventory management part of it. Right? So product selection, there may be a product whose cost is low, but volume is high. A bedpan as an example. In a hospital, used a lot, a bedpan. But you're not going to have a designer bedpan, so you're going to buy a bedpan from a manufacturer of bedpans. So you may bid for it. It may be an auction product that comes in. You may not even be directly involved with any of the suppliers that are giving. You may give it to a third party, could be a distributor who is because there's no competition there. Every hospital needs the bedpan. So the distributor gets a volume kind of a discount working with a manufacturer or set of manufacturers. They could do auction bidding on all those kind of things. So the procurement there is so different than what I'm talking about is a product selection on cancer treatment and the drugs or dental procedure and the different kinds of products there. Then once you do the warehousing and inventory, the next item is the distribution and logistics. How are you bringing it in? What's your mode of transportation? Is it inter-warehouse transfer before it goes to the final mile? How is the final mile delivered? We're talking mostly B2B in this case, right? So hospitals and other things is where we are talking about. And then how does the information systems manage this entire flow of products that are happening in a supply chain? How does your system talk to other systems? Your supplier system and your system, do they even talk? Today we have so many things people call as cloud-based solutions. If that makes sense for your particular thing, to either kind of regularize what you're trying to distribute and hire, and so on and so forth. Questions come on the key components of healthcare supply chain management. Yes.
We placed an order online, or I think we sent someone to get the medicine. Immediately the pharmacist called us. What is this medicine? Why your mother is taking this medicine? For how long, So that kind of what we can't say that check, it's a kind of more coming from regulatory confirmation, whether that pharmacist has, license to sell the medicine, that medicine is genuine, and even that pharmacist is checking why we are buying this medicine. That kind of assurance will be missing in the dark stores.
Operating from widow, like having a set of doctors sitting in their room is kind of fake doctors, you can say. They're just calling and they're asking for what is the medicine. They don't even know why the medicine is used.
Yes, as you have said, now fake doctors, and why I would get the medicine from the dark stores coming, right? So I would like to order from the origin. So dark stores is a temporary inventory storage arrangement, which doesn't need a proper shop kind of thing. You apply, you order online, it would be coming from those dark stores as a small storage facilities, right?
Thing is working on our dark store.
Most of the grocery thing, it's very easy to come.
Get from them.
Farmers, it is not.
No, sir, it is for the online providers, it's a easy some space they get closer to the customer. So as I mentioned in the morning, this is the era of quick commerce.
It's not possible.
So they want to deliver the products within 10 minutes. Now the fight and the competition among competitors is who would be the fastest and the first to send to the customer. they are giving like the assurance of delivery within 10 minutes, 15 minutes. Then they came to 10 minutes.
4 minutes.
3 to 4 minutes. This is only possible if they have some dark stores closer to the customers. They pick the goods and send that. Remember?
5 working as a delivery boy for all these quick commerce companies. Like my highest order time is like 2 minutes I deliver to the customer. So like in India, it's easy to get everything in a minute.
Yeah.
Maybe anything.
Yeah. So
I'm old-fashioned, my friend. I want to trust you before I get anything from you.
yeah. Technically, if we will say whether pharmaceutical drugs can be treated as same as other grocery products, answer is yes. But as a customer, as a patient, should we go for that? That's a caution, So that's a caution.
And otherwise, my friends in that room will get very angry. No, I'm just kidding. No. Talk to me about it. Tell me whether you understand the strengths of your healthcare supply chain management in Indian context. Look at that particular aspect, just the strengths. As an example, does the government have a role in the pricing that it can negotiate with drug manufacturers outside? Now that depends on the government's health policy on, say, curing a particular thing. When you talk about India and you go to the 60s and 70s, and even up to 80s, tuberculosis was a very big part of that. And some of these treatments were not locally available and had to be procured. So, similar thing happened for Africa later on with the AIDS. The medicines came from outside, but it was a pandemic. So, the government has a big role in terms of the procurement pricing. So, that becomes an important part. Even vaccines were the same thing, right? It's a huge debate on who got it, who didn't get it, at what price, how much was government supported. And so that's what I'm talking about from a supply chain, the procurement side of things. The second one you can think about is how much investment government is giving into infrastructure, right? In order to transport goods, things of that kind. If you think about automobile industry, a lot of investment has gone in to facilitate movement of goods across the country because manufacturing happened a lot in the southern part of India. Demand was more stronger in the northern part of India. Things had to move back and forth. And previously, before you had unfiltered access and movement of goods, what would happen is you have to have a lot of handoffs. From one state, you will hand off to another, octroi and trade duties and all these things plague the costs. Government had a role in streamlining this. I don't want to go there, but whatever that is. But an uniform kind of a tax code, if you want to call, or at least compliance rules that says you don't have to, when you're moving something from point X to point Y, you don't have to be verified in between somewhere. So all those type of things in logistics. When I talked about logistics in Malaysia, one of the biggest problems was Malaysia and Ghana, as an example, are countries import 80% of their pharmaceuticals. 80%. It's a large amount of goods that comes from a pharmaceutical company into a country. Now, what do we know about some of these pharmaceutical goods? Temperature control is very important. The efficacy of the drug reduces if they are not properly cold storaged and transported. Now, government will play a role in saying to the manufacturer like Pfizer or whoever it is, I want you to bring at this quality. But Pfizer will argue, I will do that till the port. Till the port of your country, it is my responsibility to put it into the right cold storage and bring it. Most of the countries from the port to the internal consumption, they have to do it themselves. Now here is where the cold storage breaks down. Because cost savings come in, you give it to somebody who would move it, who would not know the reason and efficacy of cold storage. So when I went to hospitals in Malaysia for certain type of drugs, I heard this as a common thing from the doctors. is our dosage had to increase because the efficacy of the drug dropped. So that is a cost item down. Instead of giving 1 vial of shot, if I have to give 1.5 vials of shot, that's a cost issue. So again, a government that says up to the port I'm going to make sure should have infrastructure in place to move, which Malaysian government then went to privatizing that particular aspect of it in order to improve. So all these things are where I'm talking about what role government plays in a healthcare supply chain. Okay, I think this is the best person to ask. The reverse logic questions all goes to, go ahead, please take it.
Strength. Okay, first reverse logistics. So as the name says, reverse. The supply chain which we generally talk about is forward supply chain. Okay, that can be forward. So reverse starts from the customer, the consumer, the patient, So how it flows back, So it is reverse supply chain, but logistics comes like, however, transportation from the product which is consumed already. Okay, so as an example, we can say that there is no clue during COVID, like, there was a abundant usage of masks, PPE, like, but how they were discarded, then what happened to them after that, right? So what are the systems there? So when it comes to like, syringes, syringes, we have very good regulatory systems, like, how to discard, how to this thing. For those things, if we would say that we have a very good system, that is a strength of our this thing, okay? But there would be challenges, like, even drugs, expiry date, like, there are very good systems, like, when the, for example, you can actually, if somebody has studied pharmacies and all, so when the drugs approach near expiry, there are very good contracts with the pharmacists, the medicines are taken back. So that is a reverse logistics, the starting point from there, So what they do, how they discard, they ensure, it should not be landfilled, like, just like that. So that system is all reverse logistics. So what are the decisions there? How to collect from, the retailers. So where supply chain comes, I cannot just take one truck for one retailer, So I have to manage, how to collect, all those things, drugs, every type of product within, this healthcare needs different kind of structure, right? How to take the syringe waste, how to take, the any like, the PPE kits, like, kind of product. So first is like, type of product, then like, how to get the logistics infrastructure, correct? Should I go to 2-3 hospitals with one truck loaded back, or one truck per hospital? So those kind of decisions are important. And then like where I should have like, the wastage hubs, like, who is going to collect first, where to bring that, what to do for that, what to do about the used products, right? Already consumed products. The whole structure is called supply chain. Is there any opportunity to reuse it? Is there any product you can think of which can be reused? Any healthcare related product, can it be reused, right? So all those decisions will be part of reverse, because if it is reused, then it has to be sent to like, route back to that point, that node in the supply chain. So that is all about reverse logistics.
This same we just see like some operations they order and they return the product like let's say.
Those are returned, this thing, returned product which has not attained end of life has to be treated differently, because first of all, the percentage of such products that needs a different treatment, okay? Because that product, if it is returned because of the reasons like, other than, expiry has achieved, that can be reused, that can very well reused in some other this thing.
Like it is a syrup. You put that package.
No, those return, that's what I'm saying. Bad quality products, defective products, or you have got wrong delivery products, those are returned categories of online products. Okay, we are not talking of reverse logistics. Predominantly deal with when the product is used. Now what to do? Mostly waste collection. Okay, this is also returned, can also be a part of reverse logistic, but this proportion is very, very small. Percentage is very small, as compared to with the broad structure of reverse logistics. Pardon?
That is also at the paper.
No, why as a patient, if something is used with me, why I should bear the cost of reverse logistics?
And then the opportunity with up.
That is the issues, who would bear the cost of? Why I should collect the waste from some hospital? Who is going to bear the cost? That's a major challenge. Okay, so this is mostly maybe government aided, hospital has to pay, right? If it can be reused, the facility which is going to reuse, that facility will pay. Okay.
They
Yeah.
properly so get those back.
Right. At least in India, the SOPs guidelines are there, how to dispose of, how to manage the waste, how to collect the waste. That is there. That's why it is strength, right? But overall, what to do after collecting, what to do, what is happening with that, that is still it's a topic of research. That's a very interesting topic of research. Even we were discussing that, we really don't have a waste, any good work on the waste management happening in the healthcare sector, how it is managed. Is there any value? That's interesting thing. Is there any value in getting the healthcare waste back in the supply chain?
Is it possible? I don't know. You tell us you working about this logistic.
We have three types of reverse logistics as per my knowledge. One is a defective equipment when it has been supplied new. Another is near expiry drugs or consumables, whatever is left over. And the third one is the consumables or drugs which have been already prescribed to patient at their bedside but not been used. Before they are discharged, they are taken back and they are not billed for that. So for the last two part, it's understood that it's at strength. But for the first one, means for the defective equipment, I think if that comes under reverse logistic, then lead time will be affected.
No, defective, that's what I'm saying. Defective item, because, if you have ordered 100 items, probably one would be defective. You cannot have a structured logistics, reverse logistics into place. It's very hard, it's definitely a costly affair. Okay. Mostly that is not the part of it.
Supply chain, the defective parts will be so less, so it can be managed. Because if you are ordering something in medical thing and it is defective, so the supply chain should be destructing huge amount of time. So it should be less defective as depending on other supply chain.
The classical definition of reverse logistics is end of life. When something has reached the end of life, what do you do with that? Most of the strategy says you dispose. What are the costs to the society of disposing? Now, that means it goes this way, it's consumed, somehow reaches the end of life, whatever the end of life is, depending on whatever the product you're looking at, and then you dispose, which means it goes to the waste, goes to the ground, it affects the environment, all those kind of things. How do I reintroduce that into a life cycle? Yes, the whole idea behind reversing that logistics that otherwise would have gone and ended. Now that has 5 R's. 5 R's. any reverse logistics. Now, I'm not saying all 5 R's are applicable in a healthcare reverse logistics, but general 5 R's, and I will talk about a few of them. 1, recycle. Right? Is any of these things can be recycled to doing anything that doesn't go back to the ground and affect the environment. You may want to think, I don't know example, but I can just tell that is one of them, recycling. Number 2 is reuse. So many of the products professor talked about single use and throw product. So if innovation can be used to convert a single use to even a 2-time use or 3-time use without affecting safety, very important in healthcare, without affecting, any other kind of compliance issues, then that becomes the reuse. That's the second R. Third R may not be applicable directly, but might be remanufacture. Remanufacture. Now, the gentleman here talked about defective. Sometimes it could be an equipment in which something could be replaced and reused. So can you use to remanufacture and claim the value? Fourth is refurbish. Remanufacture is you have to completely convert it into something through manufacturing. Refurbish is you are doing something to the existing product. I will give you a classic example during COVID that in the United States, the refurbish happened. Ventilators. Okay? Ventilators were needed during COVID more than any other time to keep the patients alive at some point in time. Many hospitals in the US did not have ventilators. Simply, this is not something you carry as inventory. You know how much you need. Tomorrow I am talking about this case, specificity. I will put a framework and see where this fits in. But today, I'll give you a gist of refurbishing. So, in California, in the United States, the governor sent out a distress call saying hospitals need ventilators. Many ventilators were sitting in warehouses, but they had to be refurbished. What does mean is they had to be taken, some liquids had to be changed, some calibration had to be tested. So there was some refurbishing that needs to be done in order to be certified for use into hospitals again. These were contempt ventilators that had to be refurbished, or end-of-life type of reaching ventilators, or ventilators that have remained idle for nearly 3 to 5 years because they were never used. And so they identified that and they created a reverse logistics network from the point of warehousing where these ventilators to companies. These were smaller, larger companies that said, I will do this for free. I have the technology, or I will train myself to do it. So ventilators would flow into this company. They will do the refurbishing, and then government announced logistic support to send them to hospitals. So refurbishing helped a lot during COVID. And the last one is reclaiming. That is, not everything is value adding in the part or the product that comes in, but part of it could be reclaimed. So those are, from a reverse logistics perspective, those are the 5 R's that normally you do. For the healthcare, it varies depending on the type of product it is. You got to be very, very, very careful, as the professor said, because this health affects the health of the people. So it is not just for economic and green reasons that you try to refurbish something or reclaim something or reuse something. So as a strength, I think the infrastructure is there in India because of the green initiatives and all to do the reverse logistics. But that doesn't mean that you have to do all of it. So that's where I would talk about that. Weaknesses, focus on that. Quality is an issue. Again, as I talked about, the efficacy of a drug is long lead times because of infrastructural struggles, which is why you are rightly pointing to dark warehouses, and because there's a way to say, I can get it fast. I can get it quickly. So when people are desperately needing for help and support, those kind of things come in. So you've got to be careful there. Certification and handling. I don't know this area very well about India, but I am suspecting the more the regulation, the more the bureaucracy, the more difficult it becomes, and becomes a weakness in terms of. So I'm saying it as more as a statement, not as an opinion. Then, of course, the threats. If you look at it, again, the same regulatory could become a threat at some point in time if it's not properly handled, because you're talking about domestic and export markets. India is a great export market for molecular type of products, right, that are used by other pharmaceuticals to produce main product. India is a great place for clinical trials. So those type of things, both threats and opportunities. Poor supplier service that could exist anywhere, not just in India, if that because of the numbers involved here. Uncertainty in demand. I mean, this is something to be careful and look at carefully. Do people predict demand correctly? Things like that kind. The opportunities, definitely, this is a place which is exceeding China today. The population growth is important. Lifestyle-related illnesses. My time of the struggle to yours, things have changed. Many more different kind of illnesses come in. The emergence of technology is a huge deal, which is what you are seeing in m-commerce or whatnot, quick commerce and things of that kind. I think a lot of these things, disposable income, so people are ready to buy. That's a big thing. So on a whole, the supply chain has, I think, more opportunities. This is what I'm thinking. Even the weaknesses can be converted into opportunities. So take a break at this point in time. Yeah.
Take a break. I'll quickly give one example.
Sure.
Visited Mumbai Gateway, of the cargo and this thing, right? So it was very interesting to see, they have a separate unit for cold chain storage, where, different kind of pharmaceutical products are stored and they are lifted by air. And they have unique packaging material, okay, so made of looks like aluminium foil, but they're very good, very strong, this thing. And they were saying every packet, it was big boxes, every box has some gadget inside which is monitoring the temperature within the goods continuously. We have not reached to the technology where, we can track and read the temperature on real-time basis, but once it would reach to the destination, you can actually get the data log, and get all the information on temperature, like what went wrong, what not. So we are actually this is a great opportunity. I think soon, we will be having some IoT device attached to that data log and get the real-time temperature also. Okay, but that's why this is an opportunity. We are actually moving in that direction. That was very interesting to know that they are maintaining the temperatures, so now we can rely on Indian supply chains, the cold chain supply chain, right? Yeah, I have to really see that, they're definitely, that's why I'm saying, in India, at least SOPs and guidelines are in place, how to dispose of each and everything, because my personal visits to hospitals, when you go, there are clear indications where you have to throw the, the used syringes, where you have to throw, if you have used some tissues and all. So they have all, that means the segregation from the source itself within each hospital is very clear and everyone is aware of that. So that means there are clear SOPs and, guidelines are there. So that's why it's a strength, but how they dispose of that, we need to check. Yeah. Yes.
Okay.
Yeah. Very, very.
Yeah.
Yeah.
This is the.
Huh. Correct, correct. Correct, correct. They can't there. Right. That is there. That's what I'm saying. There are standard operating procedures exist in India, but after his question is when drugs is expired. Now what to do? Do we have any answer to that?
There's thought.
Some experience dealing it, but this is not in the context of India, but this is in the context of Malaysia. So there is a lot of research that's going on in counterfeit medicine. So once that medicine expires, we never know what happens. For example, the medicine might be close to expiration. These people might take it, and there is a small liquid which you can use to erase the printing on the back, and then you can reprint it and sell it. So again, when there is no good regulation for the pharmacist, retail pharmacist, what they will do is if I go ask for a medicine, that guy will ask me, do you want a cheap medicine? Do you want to cost the original medicine, Cipla, Ranbaxy, or do you want a cheaper? He can always sell an expired medicine or a medicine which is close to expiry with those tags gone. This is one thing. Second thing is like totally expired, totally fake medicines, they manufacture it. And that manufacturing has two kinds. One is harmless, where they just manufacture some call as some nutrition kind of supplement, and then they will label it as some medicine and sell it. And the other one is dangerous manufacturing, just like they don't have anything that if you take you will die. That also they manufacture, they label it properly and send it. And this is a problem that the Malaysian government really wants to tackle. They don't know how to tackle the counterfeit medicines. And they are now looking at programs like how should we incentivize retailers to not purchase them, and how should we educate and create awareness among patients to not simply go to a pharmacist and ask for, I have stomachache, please give me medicine. Don't do that. Go to a hospital, go to a doctor, get the prescription and come. So this is like there are this AMR as well, antimicrobial resistance is also developing up because we are getting everything over the counter. So all these things are, a lot of research needs to be done on handling the counterfeit medicine, especially with malaria medicine and all these things. This is going on. This is something that we don't have a solution.
But I think my expectation is getting landfill or maybe burnt, or this is point in again, like regulatory framework, like it should not damage like.
Sure. Yeah. 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 Electronics. Yeah.
Yeah.
Think that way.
Yeah. No, that's why, new technologies like blockchain can be of very use. Like, to avoid this counterfeiting, to track the source, like, trace the source of everything, So for that, technologies like blockchain can be very useful.